It's me again. So I want to talk to you for a few minutes about oppositional defiant disorder versus conduct disorder. Share my screen real quick. I believe this is it. That is not it. Stop share. Let me share again and just do desktop. That will help. There we go. Shrink that down. It's this one right here. Okay. So oppositional defiant disorder. This is literally pulled right from the DSM-5-TR. Okay, I have to move me because I look at me like I'm you. And that's making everything look wonky, like I'm looking off to the side. Okay. One of the things that you'll notice here is that you need to have 6 months of at least 4 of these 8 symptoms. So 6 months of at least 4 of these, doesn't matter what 4, just at least 4. And it needs to be with at least one person other than a sibling, which is nice because I myself have a sibling. And growing up, we argued and fought all the time. So it's nice to know that there's a clear consideration of outside of the context of siblings. What's important to note is that there's a focus on there must be distress caused in others around them, and that there are specificities. Whether it's mild, moderate, or severe. And what's interesting about oppositional defiant disorder is that the severity level, the specificity of severity is based on the environment, the number of environments in which this occurs. So if it's only in one setting, only at home, only at school, only at work, whatever, then it's mild. If it's in at least 2 settings, then it's moderate. And if it's in 3 or more settings, then it's severe. And it doesn't matter what those settings are, but some examples could be, since this is most commonly diagnosed in children, would be you see it at home, you see it at school, and you see it at the after-school program. Or you see it at home with the family, in the neighborhood with friends, and you see it at school, right? So that's an interesting caveat specific to oppositional defiant disorder. And you're probably wondering, well, why, if it's a true disorder, is it only emerging in potentially only 1 or 2 environments? Why would it not emerge in several environments? Well, that's a fabulous question, or a fabulous wonder. And this really gets to some of the issues around how we operationalize mental illness. Okay, so by definition, everything in the DSM that can be diagnosed is considered a mental illness. Well, if it's a true mental illness, why would it not be 100% applicable in all environments? Why would we see contextual effects? Well, that's because sometimes it's not something that is actually within the individual, and it is something that is driven by interactions with the environment. For example, unhealthy parenting strategies could result in, and often do, the manifestation of ODD in children, and it wouldn't be uncommon to only see it occur at home. Okay. Or could be that a particular academic setting has standards and expectations that are contrary to what is typically done at home. So think about like very passive or permissive parenting. And then a child who ends up in an environment where they have strict expectations and consequences for not following those expectations might respond in a very unhappy, irritable, and angry manner, right? Okay, I won't get too much into the caveat of what are the ethical challenges and sort of the gray area of the DSM. Just know that we have more than tripled the number of diagnosable disorders in the DSM since it started. And it's not because mental health has necessarily gotten worse, although it may have, at least with the pandemic. That was quite a stressor. And it's not that we've necessarily gotten better at identifying potential health issues that need to be addressed mental health wise. All mental illness, all of the diagnoses are based on a perceived divergence of the social norm. And to be clear about that, I want you to ask yourself, who defines the social norm, right? How many people have to engage in this for it to be normal, and how many for us to then say this is abnormal, we need to do something differently, or that this indicates some kind of deficit or need or problem. As a clinician, I hope that you won't perceive all of these as a deficit, as an inability, as a disability or illness. I hope that you will, through this course, understand and learn more about the context of the environments that we are raised in, how stress affects us, and how we establish norms in order to then identify the divergence of norms. Yeah, so context matters, and it matters a lot. And the reason you will find variations across contexts is because it's likely got a strong environmental influence on the individual, which in theory, we should then call it an environmental issue, right? A parenting issue, a school issue, a societal moral issue, or a societal practice issue. But we don't do that. We focus on the individual and essentially say, this is you, this is your problem, and we need to get you to do different, be different, or hopefully help you get to experience something different because it's causing you distress or it's causing other people distress. Okay, I'm going to get off my soapbox. I want to talk about, let me stop sharing here so you don't have to keep looking at that. I want to talk about differential diagnoses for oppositional defiant disorder. Now, if you open your DSM, like I mentioned before, it's absolutely listed. It literally, if you scroll down, oppositional defiant disorder, I believe it is on page 525 to 526. You'll see the list of differential diagnoses. And to clarify again, differential diagnoses is the term that we use for potential other diagnoses that could be the root cause of the symptoms and behaviors that we're seeing. And we need to check those potential diagnoses, look at the criteria, and either confirm or reject that it is one of the other differential diagnoses. So I want to talk through some of them. So conduct disorders, one. Generally, children tend to be older, closer to adolescence or in adolescence before they are diagnosed with this. And it has an element of violence and aggression towards others that is not present at the level of ODD. Think about like physical bullying, physically harming people, animals, destruction of property, stealing from people, but not behind their back, like walking up to somebody and physically taking it from them. There's just a greater degree of callousness in conduct disorder. There's also potential for adjustment disorder, post-traumatic stress disorder. So like, for example, in children less than 6 years, PTSD may manifest initially as dysregulated behaviors, opposition, tantrums, the association with a traumatic event and with other specific symptoms are key to establishing the diagnosis. In adolescence, traumatic reenactment and risk-taking may be misinterpreted as defiance and opposition or as conduct problems. So one of the ways that you can determine, is it PTSD? You can actually do a PTSD assessment. There are several different PTSD measures. Some of them are clinician administered. Always use an evidence-based standardized measure. That means it's reliable, it's valid. Somebody studied it and said, yes, performs the same every time, and it's measuring PTSD like it's supposed to. But that would tell you if PTSD was actually at the root of it or not. ADHD is another one. And one of the things that I can't stand is when I will see people diagnosed with both ADHD and ODD. By definition, you shouldn't be able to have both. So it says that ADHD is often comorbid with oppositional defiant disorder. But here's the thing. In order to make the additional diagnosis of ODD, it's important to determine that the individual's failure to conform to requests of others in authority positions is not solely in situations that demand sustained effort and attention or demand that the individual sit still. But here's the thing. ADHD does more than just affect attention, and the DSM doesn't do a very good job of addressing this. ADHD also affects impulsivity. It affects short-term memory. So a person can look like they're just, being defiant because they won't do what they're told, when in reality, the minute that they stepped away from you, everything that you said to them just is gone. And then in terms of struggling with impulsivity, it's saying things, it's doing things. It's not just not being able to sit still. And that's because ADHD is a neurological disorder that affects our top-down processing of our brain. It significantly reduces executive functioning. You see increased potential emotional dysregulation, more impulsive behavior. You have a lot of speaking before you think about it, acting before you think about it, as well as some degree of sort of kickback of not wanting to do what they're told because of the emotional element of it. So if you're going to have a greater dysregulation of emotion because your prefrontal cortex isn't working the way that it's supposed to and inhibiting your amygdala and your limbic system, then you could be easily angered and irritated, which would then drive your behavior. And if you're a kid or an adolescent, you don't have the same prefrontal cortex development as an adult. I mean, that part of the brain is still growing up until 25 to 30 years of age. So you're going to have a greater difficulty regulating the emotions that might make you be resistant. So you could have a 7 or 8 year old kid who is very intelligent, but emotionally still functioning on a 2 or 3 year old level. You would not look at a 2 or 3 year old who said, no, I'm not doing that, I want to do this right now, and say, you're ODD. But with ADHD, there's still limited exposure in the clinical realm of understanding how those structural and functional differences in the brain actually manifest. So in the DSM, it says you just have to make sure that it's not around sustained effort and attention and being able to sit still. But again, ADHD, if you look it up on the National Institute of Health, I think it's SAMHSA, SAMSHA website, under neurological disorders, you can see that it affects a lot more than attention and physical ability to be still. It's a big deal. So how would you determine if it's ADHD or if it's ODD? If I see a comorbid diagnosis of the two, I would account for all of the ADHD symptoms. And if the ADHD symptoms cover enough of the ODD symptoms that whatever's left over doesn't meet ODD criteria, I would not give them a comorbid diagnosis. I feel like this is just stacking on sort of pathology to individuals who have a neurological disorder. It just doesn't make sense to me. You also need to consider if it might be a depressive or bipolar disorder. So you want to make sure that in order to diagnose them with ODD, that the symptoms do not only occur during a mood disorder episode, but if they don't have that diagnosis, you might want to consider if they do, right? Look for potential differential criteria. So instead of just looking at what the differential diagnosis says, pull up the list. You see the list of the disorders. And then what you do is you look up those disorders in the DSM to look at the criteria. Do they meet the criteria of those other disorders? And if that's the case, then you have to make the determination which one fits the client better. I know it's just getting more gray and more murky as we dig down into this. You're going to realize there's nothing concrete at the bottom. But some other things to consider would be, could it be like intermittent explosive disorder, which is unique to anger and irritation. But because of anger and irritation, that can create a defiant type act and behavior. You also want to consider if there might be an intellectual impairment, or if there's like social anxiety going on, because you don't want to say that someone's being defiant when it could be that there's fear of a social situation or negative consequences because of the social situation. Okay, so that's it about oppositional defiant disorder. I do want to share my screen again and show you conduct disorder. So we can talk through that one real quick. That's right here. Okay, so conduct disorder. You need at least 3 of these 15 criteria in the last 12 months, and then you need at least 1 in the last 6 months. Okay, so 3 over a year, 1 in the last 6 months, which, if you want to be honest, that's pretty awful. To have 15 potential symptoms, and if you just have 3 of them in the last year, okay, then you meet the criteria. But if you look at the criteria, like bullies, threatens, intimidates others, physical fights using a weapon, there's lots of violence and aggression. But there's also what they call like serious violations of rules. It's breaking social norms. So like truancy, running away from home, theft, crime, things like that. It also has a specifier like childhood onset, adolescent onset, or unspecified onset. So you need to be mindful of like, when do you think this occurred? And then you can also specify if there are limited prosocial emotions, lack of remorse or guilt, unconcerned about performance, shallow or deficient affect. And then you also want to include a severity specifier, mild, moderate to severe. And these are based on the types of symptoms or behaviors that the client engages in. So like mild would be a few, if any, conduct problems, relatively minor harm to others, lying, truancy, staying out after dark, so forth, rule breaking. Whereas severe is going to be considerable harm to others, forced sex, physical cruelty, use of a weapon, stealing while confronting a victim, breaking and entering, things like that. Now let's talk for a brief minute about differential diagnoses for conduct disorder. And you can find this on page, looks like 536 or 537 of the DSM. So obviously you want to make sure it's not oppositional defiant disorder. So if, and it's weird that you even have to consider the two, but the fact that conduct disorder only requires 3 symptoms, it is possible that in the mild version that you're just seeing a lot of like social norm breaking. So you want to make sure that it's not just a problem with authority and being, defiant against authority. ADHD also comes up for conduct disorder, and that's because of what I talked about with the impulsive behavior. And it's interesting because they note here the impulsive behavior, but they said this behavior does not by itself violate societal norms or the rights of others. Impulsive behavior is not defined by society. So it's pretty much when something is prompted in the moment, and that is if they have like a peer that they're engaging with, it increases the likelihood that they'll engage in things that they don't normally hold true to their core beliefs. They will engage in criminal activity. They will violate laws and social norms because they don't have the same executive functioning to be able to say, hey, you might feel bad about this later, or somebody might get hurt. So again, I really don't feel like the DSM is accounting for enough of ADHD here, but something to be mindful of. Depressive and bipolar disorders and intermittent explosive disorder and adjustment disorders. So what you do again, you look at these and you go, okay, do I see any evidence of these particular types of symptoms? Go and look at the diagnostic criteria. You need to be able to rule all of them out in order to say, yes, this is definitely conduct disorder. And then a word of note about conduct disorder. They are at great risk of developing antisocial personality disorder. And if you have a client who is in middle childhood to adolescence and they are diagnosed with conduct disorder, the prosocial behaviors and the reduction of the antisocial behaviors needs to be of prompt immediacy. Because in adolescence, the brain goes through the last time that it performs pruning, and pruning is just like it sounds. Your brain literally snips away neural pathways that aren't being used frequently in order to increase the efficiency of signaling, right? So that you can solve problems and function more quickly. In adolescence, while pruning is happening, if those neural pathways are not being used or being created, it's going to be really, really difficult to have that occur in adulthood, because the neurogenesis, the plasticity of the brain reduces significantly, right? We don't grow the same number of neural pathways in adults as we do when we're children and adolescents. So when that last round of, all right, we're cleaning everything up and this is how we're going to stage the brain, this is our final setup, if we don't work really hard to prompt development of the neural pathways necessary to engage in positive pro-social behaviors and to instill some degree of self-containment and restraint, then there's a good chance you won't be able to once they become an adult. And you're going to want to know, well, when is that? Pruning is going to be done by the time they're about 18 to 20 years old. And the last little trickle of neurogenesis is going to be finished if they're a woman by the time they're 25, and if they're a man by the time they're 30. That's the sex difference for when the prefrontal cortex finishes developing. So you got a really, really brief window to create lasting change. So that's my caveat. Because antisocial personality disorder, it's serious. It's a serious issue. You'll read more about that as we get down the line, but it's also really common in incarcerated populations. So lots of violence, lots of crime. Yeah. Okay, well, thank you for listening, and I'll see you in the next lecture.